Yes. Thank you, Larry and Perry, for inviting me to this wonderful meeting. I'm delighted to be here and present some of our data. And to give you a short impression, this is where we are working. That's our newest research building at the Central Institute of Mental Health in Mannheim, Germany, what you see here. A brief overview about what I'll be talking about. No, that's wrong. Here. And I have to do the slide presentation. Okay, now we can start. My focus will be traumatic stress and dissociation. First, I will give you a little overview on the epidemiology of traumatic stress and the etiological factor that plays an important role, as we all know, in borderline personality disorder. And when we talk about traumatic stress and borderline personality disorder, it's also necessary to talk about another disorder that is closely related to traumatic stress, which is post-traumatic stress disorder, PTSD, and it has also already been mentioned several times, because these disorders are closely connected. And I will have a look at the possible similarities and dissimilarities between these two disorders from an etiological as well as from a neurobiological point of view. In the second part, we will switch to the neurobiology and have a look at how traumatic stress influences brain morphology in PTSD and borderline personality disorder. Then again, a switch to the functional imaging. We will look at how traumatic stress or stress in general is processed in the brain, and it is very closely related to other work, for example, one that Harold Königsberg and other people at Mount Sinai are doing. And finally, a look at dissociation and how dissociation, as a very important psychopathological feature in BPD, is related to stress and how it may be treated, and finally coming up with some treatment recommendations. Okay, first regarding the etiology of borderline personality disorder. This is a broad field and a topic for a whole talk, but just a brief summary. We know that for a few years that the genetic influence in the etiology of BPD is quite high. In the large studies by Sven Torgersen from Norway, it was found that most personality disorders, but BPD in particular, has more than half of the variants explained by genetic factors, which is quite high for a personality disorder. And of course, the other important etiological factor is traumatic stress, and Mary Stanarini in 2000 summarized the state of the research so far, and it's pretty consistent that we have a high rate of sexual violence between 35 and 70% in different studies, high rates of physical violence, and what is maybe different or separating this from other disorders, and we'll come to that in a minute, is neglect, and which is very high in BPD. Okay, we have done a study in Freiburg, where we were working until a few years ago, and now in Mannheim, both in Germany, and did an etiological study with a biographical interview and looked at several factors, biographic factors, and I will present three of them. First is the violence the subjects experience that took place between their parents before they were 15. And what we did here in this study, what we thought is important, not only compare the BPD group here, 79 patients to controls, as it is mostly done in these studies, but also have another psychiatric or psychosomatic disorder, which is SF, somatoform disorder, patients that have physical complaints where you don't find a good somatic support for their complaints, often pain or other physical complaints. So, and it was, anecdotally, it was clinical knowledge that they also have higher rates of traumatic experience. So we choose this group as a control group as well, 32 patients with somatoform disorder, and I forgot the N, it's about 80 controls as well. What you see here, the violence between parents was only 10% in controls, not much higher in the somatoform disorder, but more than a third in BPD patients. And this is a significant difference between the groups. But now the classical questions were related to physical abuse and sexual abuse. What you see here, we not only asked, was there any physical abuse, physical violence before age 15, but also how often did it take place. again here in the controls, less than 10% experienced physical violence. A little higher rate here, 24% in the somatoform disorder, but nearly half of the BPD patients, here we had a larger sample, nearly 100, had physical violence. And most of these that had it experienced it more than 10 times. So it was a repeated experience, which has been known for long for sexual violence, but also here for physical abuse in the BPD's group. And the same here for sexual abuse, we also assessed that. And in accordance with the other studies I just mentioned, we had a rate of 62% that had experienced sexual abuse before age 15, and half of all subjects had frequent sexual abuse. So, and again here, not much elevated rates in the somatoform disorder. So it's a clear distinction between another psychiatric or psychosomatic disorder and BPD here. I mean, this is not new, but it confirms, mostly it was the first study that was done in Germany on this topic, and it confirms the US-American data. But now let's have a look at what possibly differentiates borderline personality disorder from PTSD. There's a very interesting study that was published in 2003 in the Journal of Nervous and Mental Disease by Plotnik. And she looked at three groups. She compared simple PTSD, simple BPD, and a combination of two. As you all know, the combination is very high. About 50% of BPD subjects also have core or current PTSD. And she compared the three groups. And as you see, for all biographical factors, sexual abuse, physical abuse, verbal abuse, emotional abuse, and neglect, for all these factors, the highest rates are found in the group that have both disorders. For example, in the group that only has BPD, sexual abuse was not higher than in the general population. And but for example, in these domains, verbal abuse, emotional abuse, they are elevated in the group that has both disorders. So it seems that these two disorders have commonalities related to these biographical factors, but the importance of the individual biographical factors differentiates these two disorders. Okay. Now, this was a brief overview of the epidemiological and etiological factors. Now we are coming to my main research focus, that is brain function and a little bit of brain structure. During my time, my research fellowship with Doug Bremner in the US, I had the opportunity to do a few studies on brain morphology, and here you see an overview of the limbic system, which is our most important brain region we are looking at. Here is the almond-shaped amygdala here in the front, and here you're seeing the hippocampus, which is processing towards the thalamus here. And these are the two regions we are mostly focusing on so far from a structural point of view, but I'll come to other regions later as well. So how is maybe stress linked to changes, possible changes of the brain morphology? There are actually two hypotheses regarding the reasons for brain changes or volumetric changes, and one is the cortisol hypothesis, which was proposed very early by animal researchers and psychiatrists for PTSD in post-traumatic stress disorder. Different changes in the HPA axis were found very early and consistently. What we looked at is how do subjects with borderline personality disorder react to stress, to stressful autobiographical memories, and had their cortisol levels assessed. We used the so-called script-driven imagery. I'll come to that later in my talk again. And we read a script, or actually here we read two scripts during this phase here. And what you see here, that the BPD subjects here, the blue start with an already elevated cortisol level. And the cortisol peak takes approximately 20 minutes. So what you see here is the peak followed by, that's following the script. And we compared three groups here, controls, PTSD, and borderline personality disorder. The highest levels were found in the borderline group, and here at these time points we had significant group differences. So the highest elevations by these scripts were found in BPD as compared to PTSD and controls. So now, as already mentioned, hippocampal volume and possible differences or changes of hippocampal volume have been assessed very often in psychiatry, and it started with schizophrenia, as you see here in this meta-analysis. In 2005, already 76 studies had studied hippocampal volume in schizophrenia, and when I came to the US and I met Doug Bremner, there were already around 10 PTSD studies, and several of them found reduced hippocampal volume, most of them, not all, but pretty consistently. And at that time point, we had 3 studies in BPD, and I also did one, and just to show you how this is done, that you have here these MR slices of the brain, and then you draw a line around the hippocampus here on the left side and the right side. You do the same with the amygdala, and this was already 5 years ago. Now you have higher resolution images. They don't look as good as they look today, and now there are also more sophisticated methods. But with these methods at this time, we again confirmed these other studies that were on out at that time, with a reduction of the hippocampus here, a significant hippocampus reduction on both sides, but also, and this is now different from PTSD, we also found an amygdala volume reduction. As you see here, even larger volume reduction, more than 20% reduced volume of the amygdala on both sides. And here I have an overview of all studies that have been published so far, besides ours, and the first was done by Martin Driesen in Germany. Oh, no, this is not working anymore. No. And he found amygdala and hippocampal volume reduction. Ludger Thewats from van Els from Freiburg, and 2 other studies found reduced hippocampal volume, and also, oh, it's working again. Thank you, Karen. And consistently, they found reduced hippocampal and amygdala volume, and this at this time was differentiating borderline and PTSD. Now there is already some work in PTSD that also hints at amygdala volume changes, but it's not so consistent in PTSD. And a study by Nicolas Rusch, who's in the audience here, did a voxel-based morphometry study, and the only region that was altered and had a reduced volume was the left amygdala. So here, not the hippocampus, but the amygdala, pointing to an important role of amygdala volume reduction in BPD. But as mentioned, it's not only these 2 regions, but they, as was already mentioned in Harold's talk, amygdala is closely related and functionally and anatomically connected to prefrontal regions. So it was obviously necessary to investigate the reduction or possible reduction of volumes in these regions. So again, Ludger Thewats van Els in his study, where he did not only look at the amygdala, but also on orbitofrontal and anterior cingulate cortex. The anterior cingulate was already mentioned, is a very important brain region in terms of decision control and also emotion regulation. And he found, again, a quarter reduction in both regions. And interestingly, there was a close association between orbitofrontal volume reduction and amygdala volume reduction. And the group from Mount Sinai published a study in 2005, looking at nicely pointing at different Brodmann areas in the prefrontal cortex, and the largest reduction in the gray matter was found here in Brodmann area 24. You see more than, I think it's more than 28% volume reduction, so even more than in the other studies in Brodmann area 24, but also volume reduction in all other areas of the medial prefrontal cortex. So these volumetric studies are all what doesn't happen very often in psychiatry, pretty consistent. And I will now give you first a summary and overview of these regions. And as mentioned, here again you see the hippocampus. We have a volume reduction in the hippocampus. We have a volume reduction in the amygdala. And here is the medial prefrontal cortex, which was already mentioned. And here the anterior cingulate cortex is part of the medial prefrontal cortex. Here where I this line goes around the ACC. Here it's the anterior cingulate cortex as part of the medial prefrontal cortex. So these three regions show structural alterations, but now there are already studies that looking at different regions, for example, connections between the two hemispheres. Nicolas Frisch just recently published a study looking at the corpus callosum density, and the thickness of the corpus callosum is reduced in borderline personality disorder. This is here, the white matter here that connects the two brain hemispheres. So you see, we're working on around these key regions and spreading through the brain, and the more regions you look at, you see, the more alterations you find. Okay, so this was the part about this structural alterations. Now we are coming to the next part of my talk, which has to do with the functional correlates of stress regulation and of particularly traumatic stress regulation. So going a little bit back to basic borderline research, our research group found that the key construct is what we call aversive tension. It's emotional stress, if you like. It's another term how we named it, aversive tension, and we found that it's extremely elevated in compared to controls. So on a scale from 0 to 9, the borderline subjects range higher than 7 and the controls around 2. We assessed this with different methods, on a paper-pencil basis, on an ambulatory assessment basis, where the patients are asked every 15 minutes during their everyday life. We always find the same, that they have extremely elevated levels of tension, also compared to other psychiatric disorders, such as panic disorder or depression. So this seems to differentiate borderline personality disorder and maybe key to the psychopathology of the disorder. And now, the first study that assessed functional correlates of this emotional stress was Sabine Herpertz from Germany. She presented these international affective picture system, like this angry dog here, and what she did, she presented these pictures to borderline patients and healthy controls, and what she found is an elevated activity of the amygdala on both sides. You see here, that was the first study pointing at elevated amygdala activity in borderline personality disorder under baseline conditions. But it looks like they are stressed throughout their regular life, as we also found this emotional stress elevated in our ambulatory assessment. So I learned this script-driven imagery method from Doug Bremner during my stay with him, and we used this paradigm where we presented scripts to them for a PET study at that time. We didn't have fMRI at that time, so we did a PET study. And the background of that was that we knew from his and other studies by Roger Pittman and others that presented these scripts of autobiographic events, mostly of so-called traumatic scripts, scripts depicting, for example, car accident or war-related scenes that are autobiographic, that are read to the subjects during scanning. And we use not only a traumatic script, because we saw already that in borderline personality disorder, it's not only a trauma per se, but also surrounding facts like neglect or other emotional abuse factors. So we decided not only to use a traumatic script, but also another script that we called abandonment script. Because studies had shown that it's not only the abuse per se, but also other related factors that can be detrimental to outcome in BPD, such as emotional abuse and neglect. And also fears of abandonment, as you all know, are an integral part of the BPD symptomatology. So we had two types of script, a neutral script, two types of stressful script, a trauma script depicting a situation of abuse and a situation of abandonment. We again compared three groups, borderline patients, PTSD patients, and controls. And all of the three groups, even the controls, had sexual and or physical abuse before age 18, so that our findings were not related, cannot be related to the factor trauma, but to the disorder per se. We used that already mentioned script-driven imagery method, which uses a personalized script of a severe childhood sexual or physical abuse event that was called the traumatic script. Then a personalized script of an abandonment situation. These were not necessarily really what you would think are very traumatic situations. Abandonment situations were, for example, children that were picked up at the preschool half an hour or an hour later, but which was experienced as very stressful by the individual subject. So it was not necessarily related to an abuse situation. So abandonment was something that had a broad variety in the borderline group. And we used a third neutral script. As readout, we used psychophysiology measures, skin conductance and blood pressure, and also, as mentioned, had first the psychophysiology measures. Here you see the two groups, PTSD and borderline subjects. What you see here in red is the abuse script, in yellow or white or what you like is the abandonment script. Here with the blood pressure you see an elevated reaction to the abuse script in the PTSD group, which confirmed a lot of other studies done in veterans or car accident survivors and so on in PTSD. And here, with the blood pressure, we did not find a much difference between the groups. There was an overall low reactivity in the BPD group. But it was different with the, when we looked at the skin conductance reactions, and the SCR, the skin conductance reaction is most closely related to emotional stress from a psychophysiological point of view. And with this measure, here we saw a significant diagnosis by script interaction, meaning that PTSD had higher levels of reactions to the abuse script, whereas BPD had the highest levels to the abandonment script. So this, you can't say it's that abandonment is specific for BPD. This would be an over-interpretation, I think, but you at least can say that they have a differential reaction to these two types of script, again pointing at different etiology of the two disorders. Now, coming to the PET findings, here with the PET in the controls, you see when they listened to an abuse script. So as mentioned, they were so-called controls, but they had a history of traumatic abuse, but were healthy at the time of the study. When they listened to the script, which was read during PET scanning, they had an activation of the medial prefrontal cortex, which is the healthy reaction. So they dampen the emotional reactivity. But what we saw at the BPD group, they had no reaction there. With PET, it's very difficult to assess the amygdala, so we did not find amygdala differences. I will come to that later. But with the other script, with the abandonment script, the reaction turned to be even worse because in the anterior cingulate, part of the medial prefrontal cortex, we had a deactivation. So the healthy reaction is the activation, but here the BPD group deactivates, which means that the natural brake on the amygdala is inhibited and you have a breakdown of emotional reactivity. Before I sum that up in a model, I want to just show that we were not the only ones that did studies like that. Another study by Martin Driesen separated borderline patients, those with and without PTSD. And here again we find a differential reaction from a physiological point of view. He used a slightly different technique. It's called cue-driven imagery. He doesn't present scripts, he presents cues from individual traumatic events. 2 or 3 words that are read during scanning. And when he does that, during traumatic remembrance, in the group that had borderline and no PTSD, they process these memories mostly in frontal regions, orbitofrontal and neighbored regions. And another picture you see in the group that has BPD with comorbid PTSD. Here you find a little activation here in the orbitofrontal, but the largest activation here in the temporal lobe, including the amygdala and the hippocampus, as you see here. And first you can say they have a differential reaction, including different brain lobes, but he also speculated about the more verbal processing in the BPD without PTSD and the more emotional processing of these memories in the group that had comorbid PTSD. And again, recent work from the Mount Sinai group that were, and I think this is the the first time that in the same study, in the same subjects, this effect that we had found in different studies was shown within the same sessions. So that is viewing emotional pictures, and you see here, you see neutral, not pictures, it's faces, sorry. And you see neutral faces, fearful faces, and angry faces. And here you see the amygdala on both sides and the ACC. You see the ACC is always deactivated. The only activation you find is with the BPD with the fearful faces. So here you have again this differential reaction with the fearful faces. Only the BPD patients show a differential activation, a deactivation in the cingulate, in the subgeneral and the medial anterior cingulate cortex, and a deactivation in the amygdala. And this is, I think it's very fascinating to show that within the same study. And as I just learned, and Antonia New has a recent study on the functional connectivity between these two regions, and showing that there's a dysfunctional connectivity between ACC and amygdala, which is, again, very interesting and building up this line of research. Okay. So to sum that up, in BPD we have, as already shown by Sabine Herberts, increased amygdala activity. We have decreased activity of the medial prefrontal cortex. And this is a vicious circle, because when the brake goes down of the medial prefrontal cortex, usually here this minus means the medial prefrontal cortex inhibits the amygdala and dampens or regulates the emotional reactivity. And if this brake doesn't work anymore, the amygdala is overreactive and maybe related. This is related to the emotional overreactivity of BPD patients. So now in the final part, I will switch to dissociation, and I want to convince you that dissociation is closely related to stress, and that this can be really or really closely investigated in BPD, because I believe that dissociation is an anti-stress mechanism. Usually, dissociation is in the first place, it's a natural reaction to overwhelming experience. For example, during a traumatic event, during any traumatic event, the so-called peri-traumatic dissociation is a natural thing that happens. But when it stays and when it doesn't, when it stays, it becomes very pathological and can interfere with a lot of processes. And I want to show you a few first results, how it interferes with learning. So, what is dissociation? I don't know if you're all familiar with it. What we mean by it, we mean certain psychological as well as somatic factors. So, a subject that dissociates usually feels as if her or himself and their environment is not natural or not real. This feeling of unreality towards the own person is called depersonalization, and towards the environment it's called derealization. And also, this is on the this is on the psychological level. And we have a close correlation to the somatic level, because the subjects also have reduced sensory processes. So they feel as if they see the world through a fog or further away. And what is also very important and what makes it easy to study is they feel less pain. And this is called analgesia. And analgesia is closely related to dissociation and makes it possible to investigate this process. As we know from psychotherapy and from clinical experience, is that in borderline patients, these states of dissociation, it's more state-related. It comes and goes, and it's closely related to emotional stress, to remembrance, to little events that are triggering these dissociative states, which occur very frequently and are very extreme often, and inhibits, for example, psychotherapeutic inventions. What we did here with a scale that Christian Stiegelmeier from our group developed, it's called the Dissociation State Scale, DSS. He found highest rates of dissociation in PTSD again and BPD, and the highest in the BPD group, even compared to other disorders like anxiety disorder, depression, and schizophrenia. And again, we investigated this not only with the paper and pencil version, but also with our handheld computer, where we assessed dissociation during the course of 48 hours, and again, replicated these findings, highest levels in borderline patients. As you see here, this is the study with the handheld computer, which has been just has just been accepted in the Acta Psychiatria Scandinavica. What you see here is the stress level, again with our scale from 0 to 9, and the dissociative symptoms. I think it's weakening, but I think you can see it on the y-axis. You see the dissociation. In red, you see the BPD, and in blue, major depression. The dotted line is panic disorder, and yellow is healthy controls. First, what you see here, the three comparison groups, these lines stop here because there were no data points here. So they stopped at 4. There were no higher levels of stress. So the borderline patients, oh, no, it's better again. Go up here, you have high stress level again. And you see this nice correlation between stress levels and dissociation, which is more or less obvious from a clinical point of view, but what we could confirm in our everyday life study with a handheld computer. And then, from a neurobiological point of view, we found, as already mentioned, pain sensitivity as a so-called somatic correlate of dissociation. What you see here is pain threshold. Pain threshold is closely correlated to dissociation. The higher the dissociation level is, the higher the pain threshold is. And this makes sense. The more you are in this spaced out state, you lose contact with the environment and you don't feel pain anymore. We then investigated the neural correlates of this disturbed pain processing, and what we did is we gave thermal heat pain stimuli on the back of the hand for 30 seconds and measured fMRI here, and here you see the I have to explain it here. What you see in red is the borderline patients, in blue the controls. What you see here, oh, now I need it, thank you. Also doesn't work, but I think you can, sorry. Maybe. Now it's better. It always works for 10 seconds, and I have to be more, save some energy here. You see in red the borderline patients, and you see this nice decrease of amygdala activity. This is all the amygdala. In blue is the healthy controls. They don't change. You don't see any change of activity, but you see a decrease. Again, and if you look at the individual subjects, you see most of the BPD subjects have a decrease, and some of the controls have an increase, some have a decrease. But in the group comparison, you see that the major reaction is the deactivation here in the amygdala, what you see here in blue. Blue means deactivation. And we did the same then in PTSD, this time not in women with abuse, but in soldiers with a UN peacekeeping mission from the Netherlands in a collaboration study with Eric Vermetten from Utrecht. And what we found here is, again, the same. In the right amygdala, here, pretty similar picture, deactivation in the PTSD, an increase, some increase in the controls, and deactivation in the right amygdala. Pretty consistent picture pointing at the potential overlap of this amygdala deactivation in these two disorders, even in different genders and in different types of traumatization. Okay, now, as mentioned, how does dissociation interfere with learning processes? And for example, learning processes, as you all know, is very important in psychotherapy. Psychotherapy can only be successful if you relearn or overlearn old schemata, or learn new connections or associations, or what you like. But you have to learn. And now I want to show you how dissociation, which is frequent in BPD, interferes with learning processes. Now it's a little bit complicated, but I'll explain that to you. This is a classical conditioning experiment. Classical conditioning is a very frequent, or it's a basic psychological phenomenon. For example, you see something that reminds you of a traumatic event. For example, a person that has been traumatized by a person that has a special facial feature, and the person sees again another person with that facial feature, like a mustache or something like that, then she has an overreaction. This is a classically conditioned reaction. You have an association between a visual feature and a pain, for example. So you were traumatized and had pain, and every time you see a certain visual cue, you feel the pain again. And this is interesting from a methodological point of view because you can easily investigate that during a classical conditioning experiment. What you do is you give an aversive stimulus. Here, that's called the unconditioned stimulus. We used an aversive cry, an aversive loud sound, and which is aversive per se. If you hear that, it's really bad. And then we gave neutral graphic patterns that were Rorschach pictures that were neutral. They should be neutral, more or less. And so one was compared with the baby cry. That is called the CS+, the one that is compared. And CS- is the one that is not compared. And you give that during different phases. You do a habituation phase. You first present only the Rorschach pictures. Then you acquire the fear reaction. You combine the CS and the US. That's here. And you also give these, the CS+ and CS- separately. And then, during this acquisition phase, you learn the association. And after that, after acquisition comes extinction, so you don't present the combination anymore. The US is dropped, and you only see these pictures again, the Rorschach pictures without the aversive baby cry, and that's called extinction. And then what is a third thing you are looking at, we will look at acquisition, extinction, and also at reinstatement. After 3 days, we had the subjects come again to the laboratory. We did another extinction study, so no unconditioned stimulus, to test whether they extinguished through the 3 days. And then you do a reinstatement. This is very important because what we think is that reinstatement is something that has to do with relapse in BPD. We know from Mary Zanarini's study that we have higher rates of remission, but our clinical experience is that they often have to show relapses and come back to treatment. So why does that happen? And it may have to do with reinstatement. So once you present the unconditioned stimulus, here in this case the painful baby cry, once more, and look whether the fear reaction is reinstated, so comes back again. And you only have to show the unconditioned stimulus for one time, and then we looked at 2 groups and see whether the conditioned reaction comes back again. So again, we compared borderline patients and controls, 32 borderline patients and 33 healthy controls. To make it not too complicated, I have a standardized a figure which combines the psychophysiological and the psychological reaction, so the skin conductance and the stress response during the 3 phases. And what we did here, we separated the BPD patients into the red ones, the BPD that had no dissociation during the experiment, and the yellow one, the ones that dissociated. Because what we saw is here, the acquisition takes place in the healthy controls, as it should be, and that's done it's possible in all animal and every healthy person that if you present these 2 stimuli, they acquire a fear response. But what you see here, the third of the group of BPD patients that were dissociated during the experiment, they simply did not learn the association. So there was no reaction, neither in terms of skin conductance nor in terms of emotional valence. So if there is nothing that can be acquired, nothing can be extinguished, and so you see here there is no extinction or not very much extinction. But then, so here you see during the acquisition and extinction, it makes a great difference if the subject is dissociated or not. But here, then in the reinstatement phase, here you find also a differential response in the non-dissociated borderline patients. They had an overreaction in the reinstatement. So the skin conductance response and the emotional valence of the conditioned response was very high in the non-dissociated. So an elevated reinstatement in borderline patients that were not dissociated is one finding, and the other is no acquisition of fear responses in dissociative borderline patients. So this is a first step of a larger research program we are conducting at the moment to look at how dissociation and other psychopathology influences learning and psychotherapy processes in BPD. And what we need for that, and for other studies looking at functional correlates, is a scale that assesses dissociation. And as already mentioned, we had developed the dissociative states scale, DSS, with 21 items but for use in the fMRI, we use a shorter scale, which we can assess on a moment-to-moment basis. And we used a scale, DSS, together with my colleague Ulrich Ebner-Prima. I developed that scale for the use in fMRI or laboratory. It only has 4 items. And for each of the 4 domains, it has 1 item. It's very brief, but it has a high consistency with a high correlation between the 21-item version and the DSS-4, the 4-item version. And it assesses the 4 domains already mentioned: depersonalization, derealization, somatoform dissociation, which is reduced hearing, and analgesia. We were not able to assess all sensory domains in this short scale. Now we did a pilot study, and these data have not been published, had been presented at ACNP last year. We included 10 patients with BPD, all free of medication, and again used a script method, in individualized script method again, a neutral situation. This time this neutral situation was also individualized, and a dissociation-inducing situation. That again could be an everyday life situation, but we asked the participant, please tell us what triggers dissociation in your case, and they wrote it up, and we presented a script that was presented by CD during the fMRI experiment. And how does that work? We present here, for fMRI you have to repeat the presentation, so we had the neutral script and the stress script. Each script was presented 3 times. We have the problem that we have always the same order, but you can't do it the other way around, because then the stress reaction overlaps the neutral reaction. So we present the scripts 3 times, each for 30 seconds. And now what is new compared to the PET studies, we assess pain sensitivity during the experiment here, these with the gray arrows, and also assess with our DSS-4, we assess dissociation after each script. What we found then is on a psychological level, we had indeed elevated dissociation with our scale. It's not very high levels, but it's higher than during the neutral script, and this is actually, we were happy with that, because we didn't want to have the subjects completely spaced out and not being able to respond to our questions, but it was elevated dissociation during the script, and even more interestingly, it has a correlation on the somatic level. We had reduced pain sensitivity here as compared to here. So psychologically and somatic dissociation can be induced with the script method. And what we found then on the fMRI level, interestingly, the 2 regions that revealed differences between the neutral script and the stress script. Here it's only 1 group, no control group. So the intra-individual comparison revealed a difference in an increased activity in the medial frontal gyrus and or ACC here, and in the right amygdala again, a deactivation. So this deactivation is again in the right amygdala, like in our pain study in borderline and PTSD, pretty consistent, and maybe related simply to the analgesia that we found, and or the dissociation. It's different to disentangle that at this time. And again here, you're happy when you're not the only one that has an interesting finding, but here a recent study, again from a German group, with an interesting design. During hypnotically induced depersonalization, they use triggers of, in healthy subjects, they trigger depersonalization in subjects that can be hypnotized. 50% of healthy people can be hypnotized, and they search for these subjects, hypnotize them, and induce depersonalization, so they induce the feeling of detachment towards their own body. And what did they find? They find a deactivation in the somatoform cortex, Brodmann area 3 up here, and down there in the amygdala, again, a deactivation. What you see here is the time course. Here in the deactivation down here, that's the depersonalized state as compared to a neutral waking state, where you have an activation and deactivation during the induced depersonalization. Okay, to sum that up, again coming to this last slide of the amygdala prefrontal interaction, we had higher activity in the amygdala, reduced in the medial prefrontal cortex, and now interestingly, during dissociation, at least during induced dissociation, we have not been able to measure dissociation on in an open field base so far, so from an fMRI point of view. So during induced dissociation, we find a deactivation in the amygdala and an activation in the medial prefrontal cortex. So just the opposite finding, and that's why I think it may be a kind of an anti-stress mechanism. So during dissociation, the amygdala shuts down, and maybe this is caused by an activation in the medial prefrontal cortex, but this is very cautiously because we haven't looked at interactions between the regions. It's just a correlational finding. Okay, to sum up the findings of stress and dissociation, as mentioned, they comprise these 4 factors. Depersonalization, derealization, and reduced sensory processes are related to emotional stress. And what we have found in our classical conditioning study, dissociation is important in that it disturbs important information processing and learning processes, and may thus be related to disturbance of psychotherapy, and may be a kind of an anti-stress mechanism, which is dysfunctional, which was once maybe during a traumatic event functional, but turns out to become dysfunctional. Just that it's not completely hopeless, this can be treated. Of course, it can be treated by a skills training to use anti-dissociative skills, as is part of the DBT training, but it can also be treated pharmacologically. What we did already a few years ago was to use naltrexone, the opioid antagonist, on a daily basis, 50 milligram, and found a reduced levels of dissociation. Here in this case, this is a psychological dissociation, also of analgesia and of tonic immobility. That is that kind of freezing phenomenon that is also closely related to dissociation. Interestingly, no effect on tension. So they were still under emotional stress. This was not changed, but the readout of the emotional tension, the dissociation, was reduced. So finally, I want to come to some implications for treatment. It's difficult to find implications for treatment, to tell you the truth, because it's mostly basic research. But I believe that this basic research has some necessity to come up finally with some treatment options. What I want to state is that traumatic factor is obviously a frequent etiological factor in BPD, but I also want to state that BPD is not the same as PTSD, as it's often put forward that it's just a complex form of PTSD. I hope I have shown you some etiological and also neurobiological facts that show that there are some distinctions between the disorders. For example, the amygdala volume reduction. Of course, as will be the topic of several talks today, emotional regulation and emotional dysregulation is closely related to a dysfunction of the limbic and prefrontal brain areas and of these circuits, and obviously the elucidation of these circuitry is one of the most interesting topics of the next years in psychiatric research. But also this disturbed regulation between these 2 brain regions may be a target for emotional regulation treatment. For example, such skills training and such simple skills such as putting ice on the back of your arm can be closely related to our findings, I think, and we are now preparing some research that investigates specific skills or psychotherapeutic interventions on a more narrow base to look at neurobiological changes that are related to a skill that is presented just for a few seconds, for example. And the final point is that dissociation is a very dysfunctional mechanism as well, because it disturbs learning processes, and also psychotherapy, which is based on and is importantly based on new emotional learning. This is the final slide. I would like to thank all people that are involved in the study at the Central Institute of Mental Health in Mannheim, the chair of our department, Martin Bohus, my co-workers, Gabriele Valerius, Iris Klossika, Petra Ludescher, and Anja Jochems. For the pain research, we are closely collaborating with Rolf Detlef Terede and his group, who recently moved to Mannheim in Germany, Erich Seifritz in Switzerland, Ruth Lanius in University of Western Ontario in Canada, who is developing this script-driven imagery paradigm for dissociation together with us, and of course with my mentor, Doug Bremner, who I'm happy to still collaborating with. And thank you very much for your attention.